alpha agonist, and prostaglandins. Looking at the efficacy, all are efficacious. However, the effect of multi-class drugs are never additive. There are certain drawbacks. Beta blockers and alpha-2 adrenergic agonists do not lower IOP during the nocturnal period. Many patients are unable to tolerate more than one agent. Even when all the four agents used in combination, IOP lowering can still be insufficient. So need of an R is a newer drug, a drug which could improve health-related quality of life, provide additional neuroprotection, economical, as well as improve the patient adherence. First in line, we have Rho kinase inhibitor, which basically target Rho kinases by regulating the shape and the movement of the cell by means of phosphorylation. It not only increases the aqueous outflow, but also provide neuroprotection along with reduced scarring of the bleb post-trabeculectomy. Natasudil was FDA approved in December 2017. It lowers IOP by three mechanisms, mainly by lowering the elevated episcleral venous pressure, decreased trabecular outflow resistance, aqueous suppression. Ripasudil was PMD approved in September 2014 in case of POAG and ocular hypertension. Both the drugs are metabolized by corneal esterase by Natasudil M1. They remain local to the site of application. They are not found systemically. Elimination half-life in cornea, conjunctiva, and vitreous humor is around 12 to 27 hours. Once daily dosing, steady state concentration is achieved in 18 days. In two phase 3 clinical trials comparing the Natasudil to timolol, found out that in Rocket 1 with BD timolol 0.5% for 3 months, it was found to be non-inferior to timolol, and the mean IOP lowering was found out to be almost equal in both the drugs. In Rocket 2, between Natasudil 0.02% OD BD with BD timolol for 6 months, it was found to be non-inferior to timolol. For Rocket 4, we have IOP reduction between Natasudil OD BD with timolol 0.5% at 3 to 6 months, and we found out there was over a high range of IOP was found between 20 to 30 millimeters of mercury, and it was found to be non-inferior to timolol. Side effect of Natasudil are conjunctival hyperemia, subconch hemorrhage, corneal verticillata, and reticular epithelial corneal edema. Latanoprostene Bu0 0.024% was approved by FDA in November 2017. It's a nitric oxide donating PGF2 alpha analog. Here, latanoprostene Bu0 is first metabolized to latanoprost acid and butanediol mononitrate, which is further metabolized to 1,4-butanediol and nitric oxide. Nitric oxide here relaxes the trabecular meshwork cells via cyclic GMP, and latanoprost acid increases the aqueous outflow via uveoscleral pathway. Latanoprostene Bu0 versus timolol in the Apollo study found lower IOP at all the time points for latanoprostene Bu0. Also, there was more than or equal to 25% reduction of intraocular pressure. When there was a comparison of latanoprostene Bu0 with timolol in a lunar study, it was found that there was more than 25% reduction of IOP. Pooled analysis of Apollo and Luna suggested higher percentage with IOP ranging less than 18 millimeters of mercury, which was sustained for 12 months. When latanoprostene Bu0 compared to latanoprost in a Voyager study, it was found that mean IOP reduction from the baseline was found to be around 9 millimeters of mercury for latanoprostene Bu0 versus 7.7 millimeters of mercury for latanoprost. Side effects: conjunctival hyperemia, eye irritation, eye pain, eyelash growth, iris hyperpigmentation, and discontinuation in 1.4% of cases. Roclatin is basically a fixed drug combination of Natasudil with latanoprost. It was FDA approved in March 2019. Side effects are similar to those of its individual components. Along with this, we have conjunctival hyperemia, cornea verticillata, conjunctival hemorrhage, and pain with instillation. The status of other Rho kinase inhibitor are still undergoing phase 1 and phase 2 trial. Next in line, we have Omlonti, which was FDA approved in September 2022. It is a selective prostaglandin E2 receptor agonist, and it works almost as well as the prostaglandin analog. Now, why there is a need of a newer drug delivery system? Because we want something which can reduce the dose frequency along with improving the adherence of the patient, ensure proper application of drug, and increases bioavailability. In this, we have punctal plug, OTX-TP, which deliver travoprost to the ocular surface via intracanalicular punctal plug, but it failed to meet phase 3 endpoint. Next, we have Meti Therapeutics has developed the Evolute punctal plug delivery system, which has been tested using latanoprost with open-angle glaucoma as well as with patients with OHT. Contact lenses. In this, we have latanoprost eluting contact lens, which was studied in glaucomatous monkeys, and it was found that it is as effective as daily administration of ophthalmic solution eye drops in animal studies. In case of if we are adding graphene oxide in the soaked and direct timolol laden contact lenses, they again are showing significant decrease in the burst release and improvement in the release profile when compared to respective contact lenses without GO. We have drug-eluting rings. They basically rest on the surface of the eye just underneath the eyelids, and they produce more than 20% IOP lowering at all the time points, but slightly less efficacious than twice daily timolol. Retention rate was approximately 90%. In phase 2, RCT compared the bimatoprost ocular ring to topical timolol 0.5%, and they reported that these rings are very comfortable and more patient preferred using them rather than eye drops. Gel forming drops. In this, we have Duracide ISV 215, which uses pentablock copolymers to form a stable mucoadhesive matrix of bimatoprost 0.03% that provide prolonged contact with the cornea, conjunctiva, and other ocular tissue. But the
I
major
think we're going to have
disadvantage here
problems
is
with the time if we overshoot time. Huh?
Hmm. Next, we have Duresta, which was FDA approved in March 2020. It's according to phase 1 and 2 study, it is non-inferior to timolol. Then we have iDose TR. It is of two type. According to phase 2 trial, it was non-inferior to timolol. Other implants are Envisia, which is extended release formulation undergoing phase 2 trial. Then we have Spyglass Pharma, which is manufactured by Spyglass System. One human study in South America found 45% IOP reduction at 9-month follow-up. Then a few words regarding drop delivery devices. In this, we have Nano Dropper, where we can reduce the drop size by 60%. We have Gentle Drop also, where basically it's a silicone device which rests over the bridge of the nose to help improve your aim and allow eye drops to get into eye better. So basically, it can be an exhausting list for sure, but the good news is that there are quite a few options available for the medical treatment of glaucoma. And the bad news is that we are still the plumbers and we are definitely looking over the horizon. So with this, it's a wrap. Thank you and have a nice day.
So thank you very much, Hemlata. Good news is that you presented very well and I'll give you a treat when you are not fasting. And bad news is that you overran your scheduled time.
Sorry, sir.
No, well done. So the next presentation is another exceptional senior resident, Dr. Anuja Patil, who is also trained in retina by Dr. Dalit Verma. So it's an asset to have her for glaucoma management, and especially he'll be dealing with lasers in glaucoma. So over to you, Dr. Anuja.
Thank you, sir. Are my slides visible, sir?
Yes, very nicely visible.
Okay.
Nice.
Good afternoon to everyone. I am Dr. Anuja and I'll be talking on lasers and glaucoma. So as we all know, laser can be used in both open angle and angle closure glaucoma. In open angle, it can be used to increase the outflow by doing a laser trabeculoplasty or by reducing the production by cyclophotocoagulation in end-stage disease. And in angle closure glaucoma, to relieve the pupillary block by doing a laser iridotomy or by modifying the iris contour by doing an iridoplasty. There are different lenses which is used to perform laser. Like for peripheral iridotomy, we use Abraham lens and Weiss lens. The advantage of Abraham lens over the Weiss is that the energy delivered to cornea and retina is 4 times less than the Weiss lens. For trabeculoplasty, we use Goldman 3 mirror lens and Latina trabeculoplasty lens. For suturolysis, we use Hoskin, Blumenthal, and Rich lens. So coming to laser peripheral iridotomy, it is the procedure wherein we create a hole in the peripheral iris to allow aqueous to move from the posterior to the anterior chamber to relieve the pupillary block, and has been indicated prophylactically in patients with PACS who have positive provocative test and one-eyed PACS patients or patients with family history of glaucoma, patients who had fellow eye PAC or PACG, and patients who required frequent dilation. All patients with PAC and PACG patients who have should be undergoing PI to reduce the incidence of subsequent attack. Also, therapeutically, we do it in acute angle closure to relieve the attack and also to reduce the IOP in patients with iris Bombay, wherein there is a secondary angle closure. It is also used diagnostic purpose for in peripheral iris, plateau iris, and also to rule out malignant glaucoma. It is contraindicated in patients with ocular media opacity, flat anterior chamber, 360-degree angle closure due to other mechanisms, and patients who are not cooperating for the procedure. So before performing the procedure, we must take a written informed consent, and we should measure the intraocular pressure before performing the procedure. In case there is an acute attack of angle closure, we pre-medicate with acetazolamide or IV mannitol, and we pre-medicate the patient with 2% pilocarpine and 0.5% proparacaine as a topical anesthesia. We select a superior quadrant of 11 to 1 o'clock position and we perform it in place where there is a thinned out iris or crypt present. We should avoid iris vessels, and we set the focus to either 0 or a little posterior defocus, so that the laser beam converges slightly posterior in the stroma. We use Nd:YAG laser of 3 to 9 millijoules power for 0.1 to 0.3 seconds duration. We give a shot of 1 to 10 shots, and if the iris is thick, we pre-treat with argon laser and then subsequently go for Nd:YAG laser. The end point is when we get a gush of aqueous coming up, or we visualize the anterior lens capsule, or there is a deepening of the anterior chamber. The hole has then thereafter to be enlarged horizontally to approximately 150 to 200 micron size. The most common complication include increase in IOP, which is seen in 10% of PACG patients. Also, hyphema, endothelial cell loss, visual dysphotopsia, cataract, anterior uveitis, and closure of iridotomy can be seen. Next procedure is laser peripheral iridoplasty, wherein we apply the laser burn in the peripheral iris so as to contract or compact the iris stroma, which opens up the angle. So this is used in patients wherein the angle closure mechanism is other than the pupillary block, that is plateau iris, ciliary body cyst, etc. It can be done in acute angle closure patients wherein there is no response to the medication and the AC is shallow. There is a marked inflammation which does not allow immediate peripheral iridotomy. So here we use a Goldman 3 or single mirror lens, and we use argon laser of 150 to 1000 millivolts power of 0.5 seconds duration. Coming to pupilloplasty, here we perform the pupillary to partially dilate the pupil by applying the contraction burn near the pupillary portion of iris. It's indicated in patients with pupillary block with cloudy cornea or pupillary block glaucoma in aphakia or pseudophakia. We use argon laser of 200 to 500 millivolts of energy of 0.2 to 0.5 seconds duration. Coming to laser trabeculoplasty, argon laser trabeculoplasty improves the outflow of aqueous by photocoagulating the trabecular meshwork. It works by two mechanisms, mechanical and cellular mechanism, wherein mechanical mechanism has a coagulative necrosis. There is a shrinkage and scarring of trabecular meshwork, which reopens the adjacent untreated area of trabecular meshwork, hence increasing the outflow. And in cellular mechanism, there is a coagulative necrosis, which results in migration of macrophages, which clears up the trabecular meshwork. Also, there is a release of inflammatory cytokines, which will increase the aqueous outflow. It's indicated in chronic open-angle glaucoma, exfoliation syndrome, pigmentary glaucoma, open-angle glaucoma, and aphakia, pseudophakia. Here we apply the laser between pigmented and non-pigmented trabecular meshwork of 700 to 1500 millivolts energy, and we use it for 0.1 seconds till we get a depigmentation spot or gas bubble at the focused site. So glaucoma laser trial had shown that the initial ALT is at least effective as initial treatment with topical medication. The success rate of ALT was 75% in 1 year, 65% in 5 years in newly diagnosed patients, and 35% at 1 year and 10% in 5 years in long-term topical medication. Coming to selective laser trabeculoplasty, here we use Nd:YAG laser of 532 nanometer. The laser is delivered to the pigmented trabecular meshwork. It limits the conversion of heat to energy to heat, and hence reduces the collateral tissue damage. It works only by cellular mechanism, so there is no scar formation and hence can be repeated and has higher safety profile. So we use a spot size of 400 micron of 0.5 to 1.2 millijoules energy for 0.1 second duration. So Latin et al., they had found 70% response rate with SLT with 23.5% reduction in the IOP. And Chan et al., they had found IOP lowering effect was independent of previous ALT. Coming to cyclophotocoagulation, so this is the procedure wherein the production of the aqueous is reduced. It's indicated in painful blind eye or eyes wherein other surgical procedure is contraindicated. It can be done by transscleral or transpupillary or endolaser route. Coming to transscleral route, in transscleral route, we use the diode laser of 1.5 volt energy for 1.5 second duration. And this can be done in 180 or 270 degrees. The energy can be increased or decreased depending upon the response, which is gauged by pop sound. We use a G probe, which is of 600 micron size with 0.7 millimeter protrusion. And we use an illumination probe to visualize the ciliary body. And just posterior to the posterior border of the illumination site, we place the probe till we get the pop sound. Then endolaser cyclophotocoagulation is a direct photocoagulation procedure of the ciliary body, which is done by endoscopic guidance. We use a diode laser of 810 nanometer, and it gives a 70-degree field of view. The maximum power can be 1.2 volts. The complication of this include a marked pain, or there can be increase in IOP. They can be hypotony or phthisis bulbi. But the most dreadful complication is loss of best corrected visual acuity and sympathetic ophthalmia, which should be explained to the patient. Coming to micropulse diode laser, it's a newer type of diode laser by Iridex Cyclo. It uses 810 nanometers of laser with a duty cycle of 31.3%. It has an on time of 0.5 milliseconds and off time of 1.1 milliseconds. The off time allows the tissue to cool down and hence reduces the thermal damage. So there is a minimal destruction, minimal inflammation, and very less risk of vision loss. Hence, it can be also performed in seeing eyes. We use a MP3 probe, which is 600 micron size and 0.4 millimeter protrusion. We use 200 millivolts of power for 160 seconds duration. The side effects include pain, inflammation, and sometimes infection. But the advantage is that it's a non-invasive procedure, non-destructive procedure, and also vision preserving. It can also be repeated. Thank you.
Thank you. Thank you. I think we should have somebody reminding them 1 minute before the time finishes.
Yeah, ma'am. Actually, Anuja has to do that job when she's
So
presenting.
she's
She's lucky
presenting.
one.
Okay. Next time, Anuja, next person, please, 1 minute
I'll
before,
ensure that, ma'am.
just
Yes,
remind
ma'am.
them.
हाँ,
I
अनुजा
would
आपका
request our next speaker, Dr. Ekta Shaw, to speak on efficacy of goniotomy in congenital glaucoma or BAN.
अनुजा पाटिल यू प्लीज नाउ टाइम एंड ऑल्सो इंट्रोड्यूस ना ढंग से इंट्रोड्यूस करो तुम कौन कौन जानता है एकता शॉ कौन है सो
Okay.
एकता इज आवर senior resident. She is exceptional surgeon. She performs trabeculectomy and phaco better than any consultant, and she also has started doing pediatric glaucoma, so she'll be speaking on goniotomy. And after this I would like to request my boss Dr. Divang Angmo to take over. That will be followed by Shalini's talk and Talveer Sidhu. Talveer Sidhu requires some nutritional supplement because she's getting very scared of speaking on lens extraction in front of Dr. Ramanjeet. So I hope she's able to present. So over to you, Ekta and Dr. Devang and Dr. Anuja, you please take over.
Yes, sir.
Hello. Good afternoon, sir. Good afternoon, ma'am. I am Dr. Ekta. I will be presenting on efficacy of goniotomy in primary congenital glaucoma. So, primary congenital glaucoma accounts for 0.01 to 0.04% of the total blindness worldwide. And it is a specific type of developmental glaucoma which is characterized by maldevelopment of trabecular meshwork. And the surgical management is the definitive management. So, we have goniotomy, trabeculectomy, and combined trabeculectomy and trabeculotomy. And how is goniotomy performed? It is performed by incising the trabecular meshwork. So it opens up the access of the aqueous humor through the Schlemm's canal. And why goniotomy? Because it is a conjunctival sparing surgery and it takes a shorter duration and the complications are less and it is also cost effective. Then why 360-degree goniotomy? Because aqueous outflow channels, they are not symmetrical throughout. So if we do 360-degree goniotomy, the entire angle is treated at one procedure. Also, it reduces the need for multiple anesthesia, parenteral stress, and cost effective. So we performed this study of 360-degree goniotomy. Traditionally, angle surgeries has been described for 1/3 of the angle or 180-degree of the angle, but we performed 360-degree degree goniotomy, and we recruited patients with presenting with the congenital glaucoma of age less than equal to 2 years and having a good corneal clarity of grade 2 or more, and children having a dense corneal haze or more than 2 years of age are excluded. And in our study, we took 52 eyes of 32 patients. And the procedure is done like this. First, nasal goniotomy is being done. As we can see that as the iris stripped off, it falls back and we can see the angle is opened up. Now the side is changed, and then we perform the temporal goniotomies in a similar way. AC is filled up with the high density viscoelastic, and with the help of a 26 gauge bent needle, the iris is stripped off and it is falling back, and we can see that there is some bleeding in the angle. And now the eye irrigation aspiration is done, and the ports are hydrated and sutured with 10-0 nylon, and air is left in the anterior chamber for good tamponade. Now we can see that this is the pre-op angle view, which shows that there is anterior insertion of iris, and in the post-op after goniotomy, we can see that the iris is falling back, and the cleft is opened after goniotomy. So we followed up our patients for a period of 12 months, for every 3 monthly up to 12 months, and we recorded the intraocular pressure and the number of anti-glaucoma medications the patients were before and post in each follow-up were recorded. And we took the criteria for success as absolute criteria with an intraocular pressure of less than equal to 18 millimeter mercury with no anti-glaucoma medication. Qualified success is 18 less than 18 IOP with 2 or less than 2 anti-glaucoma medication, and failure is defined as IOP of more than 18 millimeter of mercury on anti-glaucoma medication, and or the patients requiring systemic therapy for control of IOP. So the results of our study was as follows. We were showing the table which is showing the pre-op and post-op IOP, and the mean result was as follows, that we can see that there is significant reduction in the intraocular pressure from the pre-op value to the post-op value at a 1-year follow-up. Also, the number of anti-glaucoma medications have also reduced, and this is a significant reduction. And we plotted the baseline characteristics, that is the age of presentation, the intraocular pressure, axial length were recorded, corneal diameter, number of anti-glaucoma medication, and the cup to disc ratio were recorded. Presenting the AGM, which shows that there is significant reduction at 12 months. Also, the IOP trend is also showing that there is significant reduction in the intraocular pressure at 12 months follow-up of the patient. We tried to find out a correlation between the intraocular pressure and the cupping, or the intraocular pressure in the axial length. However, we could not find out any significant correlation between them. Now we defined the success rate already. So in our study, the complete success rate was of 40% and qualified success is 48%. And Kaplan-Meier plot was also analyzed, and we see that the IOP remains stable for about with a survival rate of more than 75% at 1-year follow-up. Now, patients who required additional surgery was about only 10% of the eyes required additional surgery, and it was trabeculectomy in our case. And the complications were also recorded in a very few eyes, which was transient hyphema, and which we could manage conservatively. So we have seen I'll just show a literature review. There are several studies which were conducted for the other surgical procedures like trabeculotomy with illuminated microcatheter, which yields also very good result. But here we have additional cost of the microcatheter, which in our case we performing goniotomy, which is very cost effective, or also combined trabeculectomy and trabeculotomy, or trabeculectomy for that matter. These procedures, they need the conjunctival dissection and also use of antimetabolites. So there is further bleb related complication, or there are other vision threatening complications are also there, and there is manipulation of conjunctiva. So this leaves a very small window for performing any further surgical procedure, whereas in our study in goniotomy, the conjunctiva is spared, so we have a large window for performing further surgeries. And there are the study by Kaushik et al. They showed that they performed goniotomy, and their results were very good, supporting our study. There were other studies by Mendicino et al., Townsend et al., and Newstein et al. They compared other surgeries with goniotomy. They found good results with other surgery, and in Kaushik et al, they found good result with goniotomy. But in our study is different from this study, is that in our study we did 360-degree goniotomy at 1, wherever in other studies they have performed angle surgery, that 180-degree goniotomy. So I would like to conclude by saying that patients with pediatric glaucoma, they often require multiple surgical procedures to control the intraocular pressure. In our study, patients with goniotomy who were unable to maintain the intraocular pressure, they required trabeculectomy. So I'd like to highlight that with goniotomy, we are leaving the conjunctiva. So what is the benefit? That we can perform further trabeculectomy or other procedure if at all it fails. Therefore, this leaves a good, and also the follow-up is also good, and the patient patient is also very comfortable and also reduces the risk of further like infections like blebitis or other endophthalmitis. So it shows very good result in our study, and we're continuing the further follow-up of these patients. Thank you so much.
That's a very
Thank
cute
you.
baby. Thank you. I think it's a safety more than anything else that really sort of goes for this 360 degrees goniotomy. Thank you.
Yes, ma'am. Thank you, ma'am.
Thank you, Dr. Ekta. We now have our next speaker, Dr. Devang Angmo ma'am, who will talk on role of MIGS in current glaucoma practice. Ma'am, please, Ekta ma'am, please do not stop sharing your screen.
Anuja, is my screen visible?
Yes, ma'am, your screen is visible now.
Okay. So I welcome everyone once again, and welcome to Neha Kamble, who has joined us a little late. So I would be speaking on role of MIGS in current glaucoma practice. Hello. So as we all know that glaucoma therapy is undergoing a period of revolution as of now. We know that medications and lasers we have been using for as the first line. And once the patient still progresses, we have filtering surgeries and tube shunts. However, with medications, we know that there are adherence problems and side effects also. Along with that, there are a lot of side allergy, toxicity. So surgery may be proposed earlier also. If the patient develops, is non-compliant or develops an allergy, but doing a trabeculectomy or a tube in early stages is also not cannot be done. So that is why the glaucoma spectrum management needed a new kid in the block, that is the MIGS, that is the minimally invasive glaucoma surgery, which basically caters to the patients who are mild to moderate glaucomas. So why MIGS? So traditional surgeries like trab and tubes have been successfully employed for several decades. However, they have been having sight-threatening complications, and being mostly conjunctival sparing, MIGS may offer a reasonably high safety profile in these patients. So this is where MIGS come into play. It basically is the bridging gap between the medications versus the trabeculectomy and tubes. So MIGS is minimally invasive glaucoma surgery. It is an ab interno approach, minimally traumatic, efficacious, extreme high safety profile, and most importantly, a rapid recovery that patient requires in nowadays time. So the indication of MIGS is very important. We usually prefer to do it in mild to moderate glaucomas, which are open angles, ocular hypertensives, patient who develops drug allergy or something. It can be easily combined with cataract surgeries. And in angle closure, one should combine with doing a phacoemulsification along with goniosynostosis. So again, advantages being that it is less invasive, less conjunctival manipulation, and good efficacy and early visual recovery. The only contraindication or the absolute contraindication for MIGS is neovascularization of angle, where MIGS should not be performed. So MIGS are mostly suitable for managing mild to moderate open angle glaucomas requiring functional distal collector channels for effective outflow. Some of the procedures can also be performed with success in recent onset secondary open angle glaucomas like steroid-induced glaucomas, uveitic glaucomas, post-VR surgery glaucomas, and post-ICL glaucomas, where we have found good outcomes as they are not chronic glaucomas and they are just early, basically early onset, wherein the collector channels are still patent and these MIGS are actually bypassing the collector channels from the bypassing the trabecular outflow. So this is a MIGS based on the MIGS can be classified based on the physiological mechanism. So if you are bypassing the Schwemm's canal or the trabecular outflow, we have the trabectome, KDB glide, GAT, and bypassing the Schwemm's canals, we have the iStent, Hydrus, Omni. And into the suprachoroidal or supraciliary space, we have the iStent, Inject, Miniject, and subconjunctival stents also. And likely MIGS that act on ciliary body are the endocyclophotocoagulation, high intensity focused ultrasound. So if we come into the anatomy, trabecular meshwork and inner wall of Schemm's canal is the site of maximum resistance. So the Schemm's canal drains to 24 to 35 collector channels, maximally concentrated infranasally, which transmit aqueous to intrascleral and then to the episcleral venous plexus. So in mixed surgery, the most important thing is the positioning of the microscope, wherein the position of the patient patient's head should be away from the surgeon, and the microscope should be tilted towards the surgeon. And the best view of TM is achieved when the angle of the microscope and that of the lens is equals to 70 degrees. So the first mix that I will be showing is the bang. I think most of us are doing bang. So bang is basically wherein we use a 26 gauge needle, and here we have used a 26 gauge bent needle, and we can see that the needle is moving, and the we can see the cleft being formed as the needle goes, and the yellow arrow is showing that part of the TM that has been stripped. So this TM can then be excised with the microforceps and scissors. The second mix is the excisional goniectomy done with the Cahoog dual blade. So Cahoog dual blade is it is basically there are two parallel blades, and it is commercially available. So we can just mark around 3 to 4 clock hours of the TM that has to be striped. And then this is the mark and meet technique. So we mark the area of the TM that has to be stripped, and then we just excise the TM. So this is being marked. And here now we are just excising the TM. We can see that as the blade is moved, you can see the wall of the Schwann's canal, and we can see the part of the TM that has cut, and it can be easily removed. Similarly, this is a micro hook, which is another mix similar to KDV, but the only thing is that this is a not single use, it is multiple use, and therefore it is cost effective. So, and last is the eye stent, which has come recently into, and the eye stent, wherein it started with 1 stent, now we have 2 and 3 preloaded stents. Usually it has to be combined with cataract surgery for efficacy. So this is just a short video. So we can see that 1 stent is already injected here, and the second stent we have gone with the injector. And now we just have to press the trigger, and here. So this in all the mix, the en-face view of the angle, wherein one should see the trabecular meshwork very clearly, only then one should go ahead and do the mixed surgeries. So all these procedures do have their own complications, but the most common being hyphema, which is usually self-limiting, and in the first week one may have elevated IOPs. And most important thing is that all these mixed procedures, patients should be have gonioscopy should be done in these patients on follow-up to check the cleft patency and formation of pus. So I'll just skip this case and come to the conclusion in. To summarize, so MIGs are not so potent, but they provide a blebless and safer option for certain patients, eliminating the need for resorting to invasive glaucoma surgeries. Combined with cataract and MIGs, they show a good efficacy and safety. There is no impact on the success of the future filtering surgery. With judicious selection of cases and MIGs, glaucoma surgery can be individualized according to the patient's affordability, the stage of the disease, and the nature of the glaucoma. And the greatest advantage of MIGS is preservation of conjunctiva for invasive surgeries in future, like trabectomy or tube implant, if required, and reducing the dreaded bleb-related complication. And we need more long-term evidence to decide the best treatment option for each patient individually. Thank you for the patient listening.
Thank you, Devang. It was very well presented and actually on
Thank you,
time.
ma'am.
So I think you've given everybody a good idea of where to do these mix. And as you said repeatedly, I think what we need is long-term studies. It is definitely an option that is now available for patients.
Respected Chairperson, this was a request from Dr. Ashwini Behra sir, who is a speaker in our session. If he can give his talk as the next talk, as he's having another talk in another hall. So, ma'am, if you can permit him to give the
Yeah,
next.
sure, Devang. What do you say? There's no problem.
Yes.
Okay, thank you so much, ma'am. So I now call upon Dr. Ashwini Behra sir, who will share his advice on how to set up a successful glaucoma practice. So please unmute yourself and share your screen.
अश्विनी तुम्हारा बहुत अच्छा प्रैक्टिस है. You should share your income also with your teachers.
Sir, good afternoon. Fine, good afternoon. Sir, my screen is visible?
हाँ बिल्कुल visible है. You please go ahead.
Good afternoon to one and all, and good afternoon to respect Ramanjit ma'am, Tanu sir, and it's my pleasure to give a talk on how to set up a successful glaucoma practice. No financial interest. Whatever little I know in ophthalmology, I always give credit to my alma mater and my teachers at RP Center. So, a proper glaucoma training and fellowship is a must before you start any glaucoma practice. And your mentor, your inspiration for life plays a major role in it, because whatever I am today or whatever I am seeing the patient or treating the patient, the influence that they have on my during my fellowship, during my residency, is plays a role, major role. In fast changing and advancing field like glaucoma, need to have to update our knowledge. So before starting our own setup, or if I want to work on a maybe another setup like corporate setup, I need to have a philosophy, because whether I'm interested just to earn money and be an entrepreneur, or I'm interested to both surgical and do a medical glaucoma, or to attend conferences, or whether I want to educate other fellow ophthalmologists by transferring the knowledge, make a success, some impact on their life. The philosophy need to be decided, because the approach again need to be changed. And fish where the fish are, that is very important, because if I want to start a only dedicated glaucoma practice, it takes a lot of time, effort, and the approach will be different, because the other surgeons who are doing other surgeries like cataract, retina, they will refer patient to me. But if I want to practice glaucoma along with other surgery like cataract, squint, and retina, they would not refer their complicated cases or glaucoma cases to me. The approach would be totally different. The first need is hospital space for the setup, and these instruments cost a hell of a lot, very costly machines, because in government setup these things are, but in private setup I need to buy all these machines, whether it be a DLC machine or OCT or visual field, everything costs now 20-25 lakh rupees, and every time there is a annual maintenance cost, CMC cost added to it. So that need to be done. But beside that, the most important part is clinical skills that you have acquired. The gonioscopy, there is no replacement to it. There is no replacement to surgical skills like trabeculectomy. And the most important part is history taking, like family history, trauma, and steroid use history. But the concept of target IB need to be understood to patients also. During my practice, I need to make the concept of target IB to the patient in simple language, because what I see, still most ophthalmologists believe 21 is the normal IOP, and with 0.9 cupping, 14-16 pressure is the NCT. They don't do appliance tension, and they tell the patient that it is normal, and you keep on following. And the patient keep on following with them, and the vision gets almost to no peer. So need to talk to the patient the simple language that it is a relative thing. 14-16 might not be adequate for you. So you have to make the patient understand this part of, because this counseling part plays a major role in private practice, and record everything. It's a lifelong disease. Need to see follow up. The one practice that I got from RPC is just write a big letter, lifelong follow up on the front of the page, so my staff also knows. Always have a backup of the documents, because patients sometimes lost their files, and record is necessary for medical legal purposes also. And when it comes to private practice, they need marketing also. So first is internal marketing, like treat our staffs well, because they should be our first and foremost well-wishers. Because it says you don't build a business, you build people, and then people build the business. Why it is necessary? Because patient might be staying 5 minutes in my chamber, but patient might be sitting 30 minutes outside my chamber. If my staffs know about how to counsel a patient, a glaucoma patient, clear their doubts, make them comfortable that no, you need to put medication on their mobile, and counsel that you need to follow up on the regular basis, that gives a more impactful, and that is very important. So, but in this materialistic world, marketing also plays a very role. People should know, yeah, I am here in Barampur, and I am from AIIMS. For that, you need marketing, online presence, education platform like YouTube, Facebook, Instagram is necessary. Whether I like it or not, people do search for Google reviews and do come with that only. Teaching your colleagues in your area is also very important, to educate them regarding what your expertise, like my expertise glaucoma, I teach them so that they also realize, okay, after that I will not able to control this part of glaucoma, they will refer the patient to me. And fellows are most important because they ask silly doubts, they keep you on a toe, they make you realize that you are still something to learn. There's so much thing to learn, not just to for show off, but really impacting someone's life, like I have been impacted by my teachers. So it makes a sense. Excellent clinical acumen is more important, but by adding knowledge through seminar, webinars, and conference. But mind you, to distinguish between what need to accept and what needed to be rejected is very important, because there are so many conferences, so many presentations. Every one and now have their own theory and their publications are there. So you need to accept what need to accept and what need to reject it, and that too with your setup. Because I might not have that kind of setup what RP Center have, but you need to have that distinguishing feature. Always look up to your role model in field of glaucoma. Effective communication to the patient is most and most important. Need to see the whole picture during in private practice also, because patient is too old, young, affording or not affording, and you need to tell to the patient the same. I might be doing that voluntarily, but I need to communicate that to the patient that see this medicine costs around 200, 300 rupees. You need to put one drop only. Don't put more than that, so that you'll be put more than that, the medicine will finish in 15 days. I am giving you lower medication, lower cost medication because you are not affording. So these things need to be communicated. Counseling is the most important part in glaucoma. Every time a patient comes to me for first time in glaucoma, I counsel them for 10 minutes. I clear their doubts, because I know if I don't clear them, at that point they will never going to put medication, because they have been doing that for mistake before also. Because as a medical profession, I also not able to put medication or take drop beyond 3 or 4 days. So putting a drop every day in day out at the same time for lifelong, it's need a proper counseling. So counseling is most important part. Being proactive and accessible to other platforms is necessary. As a doctor, as ophthalmologist, my vision is up to the ophthalmologist or medical fraternity. What we think, once we finish our fellowship, we expect our OPD to fill automatically, which does not happen. So invest in community like Rotary Club, Lions Club, BNI. I'm a president in a BNI Vibrant Club. There are many other people are there beyond ophthalmology who are master in their field. We need to communicate with them so that they should know that there is somebody who treats patients like that. So building relationships is also more important. Healthy relationship with ophthalmologists. What I see in many part of medical college in here also, professors see their student as a competitor. They don't teach that because they will learn and they will create a competition there. So never think that as them as a competitor. Once they refer a case, be prompt to see them first. Offer additional assistance to their referred patient. Write a thank you letter to them. Okay, this patient has been seen and this is the condition. So do a success is doing ordinary things extraordinarily well. I don't have to do a extraordinarily latest surgery or latest thing or in my setup, but I have to do a simple thing, counsel well to make the patient understand. If needed, it need to refer at the timely. That also plays a very important role. Seniors to mentor life. We have our group where I have a close group every day now. We have some sort of complication by me or anybody else, because that is the life of a glaucoma surgeon. So when you post there, they give their opinions. That gives your life, makes your life very easy. Achievement of long-term success satisfaction is most important. Working in an environment that you don't enjoy, I don't enjoy, will burn out, and I will not, sooner or later I will leave that part. And finally, in this materialistic world, money is not everything, and at the same time money is everything, because without money the company will not sponsor a conference. Without their vested interest they will never invest. Without that the new innovation will not come. So yes, it is necessary, but that does not mean a patient with lots of money will get back their vision if they are blind. So there's a very thin line between these two. So I would recommend it is always necessary to distinguish between these two parts, whether there should be a clinical decision should be have an upper hand over the financial income. Then only a doctor's life and the profession, noble profession will remain. So these are my teachers. I always who taught me about glaucoma. I'm indebted to them. Thank you, sir.
Thank you, Ashwini. That was very, very well put. I think talking to patients and being sort of optimistic and, listening to their problems and solving what their problems are. Very often they come with irritation and things, and we are measuring IOP and saying IOP theek hai jao. But it is their problems that need to be actually taken care of, and counseling, as you said, is very important. Thank you.
Thank you.
Thank you, sir. I now invite Dr. Shalini Mohan, who will speak on how to perform the perfect trabeculectomy. Ma'am, please unmute yourself and share your screen.
Is my screen visible?
Yes, ma'am, it is visible now.
Ma'am, please do slideshow.
Is it okay now?
Yes, ma'am. No slides. Yeah, now it's fine.
Okay. Thank you so much, Dr. Anuja. It's real proud privilege to present how to perform trabeculectomy in front of my mentors, Ramanjeet ma'am and Tanush sir, who have actually taught me how to perform trabeculectomy. So we know I don't have any financial interest. We know that trabeculectomy is the gold standard surgery and it gives better control on diarrhea variation and also effective in disease progression. And success rate of trabeculectomy is also good if performed with perfect to achieve target intraocular pressure, or there are problems with medical management like progression of glaucoma or certain adverse effects of the medications, poor compliance, affordability, and poor availability of drugs. And then also difficulty in follow-up. So regarding anesthesia, generally we give periberber or retroberber, but the point is that we have to avoid the pinky ball. It is better to give intermittent digital massage with your hand. Under general anesthesia is used for children and uncooperative individuals. But yes, nowadays people are using topical anesthesia also in cooperative patient with intracameral topical anesthetic agents. So previously we used to put traction suture by superior rectors, which used to buttonhole the conjunctiva and damage it. And therefore, nowadays we are better to place a corneal stay suture. First, assess that how is the pressure inside the globe, and then only proceed with the surgery. And then put a corneal stay suture. I will start with this video. So you can also do it under block. So here I'm putting the corneal stay suture. 80 Vicryl is very good because cornea is thin, but you can take 60 Vicryl in case it is not available. Now it gives a good exposure, and then you start dissecting the conjunctiva. So whenever you're making the flaps, it can be fornix based or limber based, but fornix based are preferable these days because of the overhanging black problem is not there. So again, let us see, this is another patient where exposure was good and therefore I have not applied any stay suture. You can also take the speculums these days, which give a wide exposure. Gentle cauterization is mandatory. You should not over cauterize because it is we don't want any thinned out scleras. Now make a horizontal incision of 4 millimeter and then freshen it with your crescent knife. Now we need to dissect a partial thickness scleral flap just like you do it for your small incision cataract surgery. Now this was another patient where there was lots of fibrotic bands due to the long-term medication use. So you have to be more meticulous in the dissection. Now you dissect in one end with the help of a crescent knife and then go anteriorly at least 1 millimeter into the cornea. Then make your side port so that you decompress slowly. Satisfied. Like here it is okay, but here it is smaller. So you must punch again with the help of sclerostomy punch so that you get an adequate sized opening. So now if the opening is adequate size, you are satisfied, then you proceed with the iridectomy so that iris doesn't come and block the ostium. Once you are through with the iridectomy, then of course you have to suture it. So you can put two non-releasable sutures if you have a laser suture releases facility available. Otherwise, you can put a releasable suture. So this is Cohen or Osher's technique. I'm putting 4 throws at your suture time forceps. Pull this loop out of the knot, and now this is the releasable suture which you can release on the table. Conjunctival closure is very, very important. Taking partial thickness in the sclera is mandatory, and then you suture the conjunctiva. There should not be any leak, especially in the fornix-based flap. So putting two wing-shaped sutures at the both ends of conjunctiva, if you feel that the conjunctiva is not properly opposed at the limbus, better to put a corneal stay suture over it so that there is no bleb leak while the bleb is in the forming state. So this is putting one of the suture, make sure that all the knots are buried nicely. So let's revise this step again. So in a fast forward manner, partial thickness scleral flap, conjunctiva, tightening it nicely. You have to make sure that there is a horizontal line at the limbus, which is needs to be tight enough. If it is not, then again putting a corneal suture so that there is no leakage of fluid from the bleb at the limbus. So now again tightening your knots and therefore surgery is complete. If you feel that there is sometimes you might see that conjunctiva is overriding over the cornea like this in some of the cases. So better to trim this conjunctiva to avoid any overhanging bleb. So this was another case in which conjunctiva was overriding. So nice. Now after that, always check by injecting fluid from the periphery that the bleb forming is nicely. Check that the anterior chamber turgor is okay. It is neither too tight nor too low. And then give subconjunctival injections of gentamicin and decadron and close the eye, catch the eye. So I was talking about limbal based where there is a restricted posterior flow and formation of ring of steel, but I have seen that if you do it nicely, both the techniques well, it can be surgeon's preference. So now bone healing modulation is important. Mitomycin C is widely used. Nowadays, subcutaneous mitomycin injection are being preferred because it gives a diffuse bleb. Although the IOP reduction is same with the sponges or the injections of subtenon injection of mitomycin C. So this was the sponges which were being used. So it is a good idea to check with the fluorescein dye at the end of the surgery so that there is no leak of the aqueous so that we have a good bleb formation. So modifications came in with Ologen and with Express implant, but nowadays the standard trabeculectomy, which we all were taught, is the absolutely perfect surgery. So to conclude, I would say that trabecular the gold standard. We should assess the risk and benefit ratio whenever we are advising the surgery to our patient. Proper patient counseling is must because in immediate post-operative period, there might be some reduction in vision, which should be properly explained to the patient. And then, of course, more stricter follow-up is required in comparison to cataract surgery for all our glaucoma patients. Thank you so much for kind attention and my gratitude to my mentors, Madam Ramanjeet ma'am and Tanish Dada sir. Thank you so much.
Thank you, ma'am, for covering a step-by-step guide on trabeculectomy surgery. I now invite Dr. Talveer Sidhu, ma'am, who will discuss the role of lens extraction in angle closure glaucoma. Ma'am, please share your screen and also unmute yourself.
Thank you, Shalini ma'am, for such a wonderful presentation. And the videos, I think, our residents, they usually benefit with all these video-assisted talks. Talveer is ready, meanwhile?
Yes, ma'am, I'm ready. Good afternoon, everyone. Good afternoon, my teachers and mentors and colleagues. Am I audible, ma'am?
Yes, ma'am, you are
Yes,
Am I
audible.
audible?
Yes, yes.
Thank you. Role of extraction is the most favorite topics of any glaucoma present. Usual protocol for management of closure glaucoma. We all know that lens extraction is not anywhere in the management of angle closure glaucoma as such. That said, we all know that only 20% of chronic angle closure glaucoma patients need surgery for glaucoma control. And this has been taken up from the 10-year follow-up of angle closure glaucoma patients by Professor Sihota ma'am. Does cataract surgery really help or lens extraction really help in managing intraocular pressure in angle closure glaucoma? So we have two Cochrane reviews and then we have our EAGLE study. The Cochrane reviews by David Friedman et al., it says that there is no evidence from good quality randomized trials of the effectiveness of lens extraction on chronic primary angle closure glaucoma. Also, another study which compared laser therapy with lens extraction, it says that there are a lot of complications of lens extraction, whereas it makes little or no difference to the quality of life, vision clarity, or eye pressure. It may reduce less than one medication of the patient, but nothing else. Now, Eagle study is actually it's a controversial study. Why? Because it compares lens extraction with laser iridotomy. So now, when you talk about lens extraction with, they have also included patients who have both synechial closure as well as people who had closure without indentation. But when you look at the results, they have shown that a lot of the data is missing, especially in synechial angle closure. More than 50% of the data is missing at the end of the study. Also, when they talk about the complications, they said that both lens extraction and the laser iridotomy have similar complication rates. However, intolerance to medication was the major complication associated with with the laser therapy. Therefore, the drawbacks of the Eagle study are very prominently there in the face of everybody. That angle closure actually, advanced glaucomas here were not included. Moreover, LPI complications are actually in practice not equal to that of lens extraction. When you talk about long-term outcomes of cataract surgery in severe or end-stage angle closure glaucomas, majority of the studies say that around 15 to 10% of the patients can actually lose significant visual acuity after cataract surgery in angle closure glaucoma and may require subsequent trabeculectomy. Now, coming to endothelial cell loss, it is negligible in laser iridotomy, whereas in phacoemulsification, there are higher rates of endothelial cell loss following cataract surgery in angle closure glaucoma. When you look at normal cataract extractions without angle closure, most of the complications which are present are under 5%. But when you look at cataract extraction in angle closure glaucomas, you see that majority of patients, even up to 10% of the patients, can suffer corneal decompensation or increased inflammation or IOP spikes, and they may also require trabeculectomy later on. Also, we all know that microscopically, the trabecular meshwork beams have already fused in angle closure glaucoma, and that is why the IOPs are really high. So, taking care of the lens does not really help in managing the intraocular pressure. So, my conclusion is that cataract surgery may produce a very small drop in intraocular pressure, which might be similar to LPI. It might lead to less than one medication reduction in patients, especially in angle closure and not in angle closure glaucoma per se. Therefore, clear lens extraction or cataract surgery is not the treatment of choice for control of IOP in angle closure glaucoma. Thank you.
Thank you, ma'am, for nicely explaining the role of lens extraction and how it can be considered as a treatment plan for angle closure glaucoma. Ma'am, I would now request Dr. Parul, ma'am, to speak on status of newer IOL for glaucoma patients. Dr. Parul, ma'am, please share your screen and unmute yourself.
Good afternoon, and thank you to the RPC Glaucoma family for giving me this opportunity to share my thoughts about the status of newer intraocular lenses for glaucoma patients. So, no financial disclosures. There are two truths that cannot be denied, that even now we don't have a perfect IOL that satisfies everybody. And glaucoma patients, like all other patients, require a perfect refractive cataract surgery. Now, there is a huge element of unpredictability in terms of outcome for glaucoma patients because these patients have smaller pupils, especially in angle closure patients or patients who have had pseudoexfoliation. They have denser cataracts, shallower chambers, and weaker zonules as compared to normal patients. And remember that there are no free lunches in optics. So, whenever we are adding an element of accommodation or diffraction, refraction in terms of a multifocal IOL, there is going to be a compromise to these glaucoma patients. Now, let's see what are the avenues that are available for our glaucoma patients. We have multifocal IOLs, the EDOFs, the accommodating IOLs, and the toric lenses. And let's explore each of these avenues individually in the forthcoming slides. So first things first, as a doctor, all of us must understand the pros and cons of different lens types, and therefore knowing the optics of a particular lens that we are using is quintessential, and we need to relate this to the structural and functional changes that are associated with glaucoma. So let's have a look at multifocal IOLs. We all know that there are diffractive, refractive, or hybrid designs. There can be bifocal or trifocal lenses, and the implantation approach can also be different for different surgeons. Some doctors like to use a single type of multifocal IOL in both the eyes, and some others like to do a mix and match or a blended vision approach. Now, the pros of multifocal IOLs include the good distance and near visual acuity. While there are several cons for them, they include the decreased contrast sensitivity, subjective photophenomena like halos and glare, which itself manifests into a very difficult night driving. The diffractive models of multifocal intraocular lenses results in these line artifacts in OCT readings, which can at times cause a misinterpretation in the outcome. And they also cause a decrease in the visual sensitivity when the patient is undertaking a visual field test. So to use or not to use for glaucoma patients, it is better to avoid these lenses for glaucoma patients, as the study has shown when compared the use of multifocal IOLs in controls, pre-perimetric glaucomas, established patients and dry AMD, that all the glaucoma patients reported difficulty in nighttime dimming. And as we move from mild, moderate, and severe glaucoma, this difficulty becomes worse in patients who have had a multifocal intraocular lens. Next comes the extended depth of foci lenses. They can be pure EDOFs or hybrid multifocal EDOFs. We all are very well aware of it and using these quite rampantly these days. A good thing about these lenses is that there is a light channel which allows you to have an intermediate zone of visual acuity, but the blur that is formed because of this channel is very minimal and therefore is very well tolerated by most glaucoma patients. So these lenses have better contrast sensitivity than multifocal IOLs. EDOF lenses cause a contrast sensitivity reduction of just about 7%, unlike the traditional multifocal or the trifocal lenses where it ranges to about 15 to 20%. The non-diffractive EDOFs like Alcon Vivity are better than the diffractive counterparts. There are no particular cons as such, so to use or not to use for glaucoma patients, the answer is a big yes. And typical EDOF glaucoma candidates include patients with controlled pressures, mild to moderate disease with very peripheral visual field defects, and for the EAGLE followers, which Talveer has very well explained, that patients where you are considering a cataract surgery in the presence of cataract, EDOFs can present as a good option. Talking about accommodating IOLs, the pros are that definitely they improve the distance and the intermediate vision without decreasing the contrast sensitivity. They do not depend on the pupil size and therefore cause less photic disturbances. But the major con with them is that there is a higher risk for capsular contraction and more commonly in pseudoexfoliative glaucoma. So although these are not very commonly available, it is better to avoid them for glaucoma patients. The pro tips for any such lenses is that we need to educate the patient on the time required for neuroadaptation. If you choose monovision for your patients, a contact lens trial prior to the surgery is a good idea. And don't forget to obtain a new baseline glaucoma testing following cataract surgery. Let's look at the toric IOLs. They correct the astigmatism which has been induced by previous trabeculectomy, and they can be used for all severities of glaucoma. But there are certain calls in pseudoexfoliated glaucoma patients with small pupils and zonulopathy. Possible risk of IOL decentration is there. Axis misalignment or dislocation can also occur. And there is a factor of unpredictability when we are considering these for along with a phaco trap. And these need to be avoided in patients with central vision loss. To use or not to use for glaucoma patients, I think they can be used in combination with refraction neutral mixed procedures. And here prefer mixed surgery, which causes less bleeding and so, less alteration in terms of the outcome with these. The status of femtosecond laser cataract surgery for glaucoma patients, there are certain pros that they are good for cases with weak zonules and shallow ACs, as in pseudoexfoliation glaucoma, angle closure, or traumatic glaucomas. But the cons include that the pupillary dilatation challenges can preclude flax, and we need to avoid suction rings on thin and ischemic blebs, and transient intraocular pressure elevation can be seen. So therefore, it must be avoided in advanced glaucoma cases. So my take-home messages is that the EDOF lenses or the lenses that are suitable for your patient can be used for glaucoma suspects, ocular hypertensives, and early glaucoma. And the choice of individual of IOL base is on an individual basis, considering patient's motivation, their visual expectations, the rate of glaucoma progression, the surgical risks in terms of zonular stability, and so on and so forth, the pupil size, and the ocular surface. But we still await the smart IOL, which will address the problems for all glaucoma patients. Thank you very much for making me a part of this event. Thank you.
Thank you, ma'am, for giving us an insight on the newer IOL for glaucoma patients. With this,
Thank
we
you.
conclude
Yeah,
this.
Anuja, yeah,
Yes, ma'am.
yeah. Thank you, Dr.
Yeah.
Paral, for such a comprehensive talk. So just to open up the discussion, Dr. Munish is there, Shalini ma'am is there. So, I mean, what do you prefer in your patients? How do you go about it for your patients? What is your
I
choice?
definitely don't use a multifocal IOL, even in mild glaucoma patients, because ultimately the disease is going to progress. So as a rule, if the patient can afford, I would always use an EDOF lens. And for angle closure patients with advanced disease, I always keep a backup of a 3-piece lens, because you never know where you end up with a surprise rent. So EDOF is a preferred choice. And in cases, as I suggested, a 3-piece is a backup sometimes.
Munish, Dr. Munish, sir?
Dr. Devan, first of all, thank you very much for making me a part of this event. As Dr. Parul has very clearly explained that EDOF IOL is very well preferred IOL for these type of patients. We should not go and we should not make the patient expectation very high. We should be very realistic with the patient, and I think in today's era, up till today, EDOF IOL is the best IOL which is available to us for even, I will say, all type of glaucoma patients.
Okay, and ma'am, what about your take on toric IOLs? Like, especially if it is a we are not combining with trap, or patient has already undergone a trabeculectomy, and now you want to plan.
Yes, so 6 months post trabeculectomy is the time when the entire astigmatic scenario has sort of settled. So in those cases, yes, if the astigmatism is significant, we can definitely consider a toric IOL. So, but yeah, you have to tune this as per the location of the bleb and as per the astigmatism which the patient is having. I wait for 6 months for all these refractive parameters to settle before considering toric.
And have you ever had a surprise? Because we never know what mitomycin is doing. So, I mean, I'm not very this thing about whether to.
I am a little conservative when it comes to the toric IOLs in patients who have already had a trab, and that's why I didn't really mention it in the first go. Unless until the astigmatism is significant and it's going to disturb the patient's post-op refractive outcome, I usually try to put an EDOF, and in case there is astig, I try to adjust it with an OCCI. I try and avoid putting a toric IOL unless until it is significant enough and it is, going to affect it is not going to be benefited with an OCCI.
Okay, ma'am, thank you. Thank you, everyone. Thank for joining us. And with this, we'll conclude the session.
Thank you, Dr. Devan. Thank you so much.
Thank
Thank
you.
you.
Thank you so much.
Okay.
Thank you, Talveer. Thank you, Avneet. Thank you, Ekta. Bye-bye.
Bye-bye. Leave webinar.
Recording stopped.